ये डिप्थेरिया कहाँ गए? ठीक है, बंद कर देंगे बटन. Good morning. Today I am going to teach you the three most important infections of the childhood. That is diphtheria, pertussis, also known as whooping cough, and tetanus. Once upon a time, they used to be very dreadful diseases, but with the invention of the latest vaccines, DPT, their incidence has reduced tremendously. But still, we get often on the cases where the immunization is poor or there is no immunization coverage due to the poverty or ignorance. Not poverty, because government is giving this vaccines free everywhere in Anganwadis also, but people due to the ignorance, even they don't visit the Anganwadi, so they don't get immunized. So outline of all these three topics. First, I will tell you the specific learning objects, then definition, epidemiology of the disease, then etiopathogenesis, clinical features and various types, then complications, its diagnosis and differential diagnosis, management, and most important is the prevention and control. To have the infection and treat, so better is the prevention and control rather than the having the disease. So specific learning object of this lecture is at the end of this lecture, the student must be able to identify the definition of the disease, causes, clinical features of diphtheria, tetanus, and pertussis. Then identify how these diseases are transmitted and how to prevent them, diagnose the disease, and know the management. So first of all, I will start with the diphtheria. This is arrived, this word arrived from the Greek word leather, acute toxin mediated disease caused by toxicogenic bacteria, Corynebacterium diphtheria. It is the first disease remarkably decreased following the immunization. Now occurs in the unvaccinated children and adults who have lost their immunity. I have already told you that now it is very rare to get disease, but still we are getting the cases. Now, epidemiology. Corynebacterium diphtheria is the main culprit or main bacteria that is causing this diphtheria. It is exclusively inhabitant of mucous membrane and skin. Worldwide, it is more in winter season. And before Second World War in 1920, in US, more than 12,500 cases with 10,000 deaths. But now, due to the DT, less than 5 cases annually, and then no epidemic of respiratory diphtheria occurs. Outbreak keeps on occurring in developing countries as a major one from the countries of Soviet Union in 1990 and recently from Nigeria in 2011. There was an outbreak or epidemic. In India, it is an endemic disease now, and though the number of cases decreased significantly. Now, what is the etiology? Corynebacterium diphtheria is aerobic, non-capsulated, non-spore forming, non-motile, pleomorphic, gram-positive bacteria. And its mode of transmission is direct contact. Number 2, it can be spread by droplets of secretion. Third is exudate from infected skin, and its incubation period is 2 to 5 days. Now, pathogenesis. They proliferate and liberate a potent exotoxin which inhibit the protein synthesis and causes local tissue necrosis of epithelial cells and liberates a serous and fibrinous material which forms a grayish-white pseudomembrane, which bleeds on being dislodged. Removal is difficult and reveal will bleeding and edematous submucosa. So this pseudomembrane which is formed, it is like a leather. That is why this name is given diphtheria. This pseudomembrane is very difficult to dislodge it and it bleeds usually on touching. Now, what are the local effects of toxin? It causes paralysis of palate and hypopharynx, and a pseudomembrane is formed, which may be causing the obstruction. Then systemic effects are affecting kidneys, heart, and myocardium. So it causes thrombocytopenia and demyelination of nerves. Now, clinical manifestations of diphtheria. Its onset is acute with fever, malaise, headache, and toxic look. The manifestation depends on site of infection, immune status of the host, production, and systemic distribution of toxins. Most common sites are number one is the respiratory tract diphtheria. That is the most common. And fascial or tonsillopharyngeal diphtheria, that is the incidence is 94%. And after that, among the respiratory tract diphtheria, second is the nasal diphtheria, and third one is the laryngotracheal diphtheria. Then, after respiratory tract diphtheria, number two commonest is the cutaneous diphtheria. That is on the skin. The lesions are on the skin. And third is the infections at other side. So now you can see in this diagram, see this. This is the whitish is the pseudomembrane over both the tonsils, and it is extending over the pharynx, hypopharynx, and also covering a part of the uvula. So first of all, I will teach you about the commonest respiratory tract diphtheria, that is the fascial diphtheria. And its incidence is, I told you, 94%. Sore throat is the universally early symptom. And fever occurs in the 50% of the patient. Then occurs because of the pseudomembrane, and obstruction occurs, and then the symptoms cause dysphagia, that is a difficulty in deglutination. Then as it extends and extends towards the larynx, then the hoarseness of voice comes. There can be malaise or headache. Then unilateral or bilateral tonsillar membrane formation, which may extend to uvula, paralysis, soft palate, posteriorly, oropharynx, hypopharynx, and glottic area. So soft tissue edema plus enlarged lymph nodes, they form a bull neck appearance, which I can show you in this diagram. This is the soft tissue and lymph node enlargement. This is causing the bull neck appearance. And this is the difference between the tonsillitis and diphtheria. See the tonsillitis and see the streaks of the exudate, and in between the normal tissue is appeared slightly inflamed reddish. But here you cannot visualize the tonsil tissue. It is all covered with the pseudomembrane, and it is extending and causing obstruction also. Here there is no obstruction. Okay, so this is the difference. Now, second type is the nasal diphtheria, that is unilateral or bilateral purulent serosanguinous discharge comes from the nostrils. Then erosive rhinitis with membranous formation and excoriation of upper lip. Now, third is the laryngeal diphtheria. The membrane over larynx leads to brassicough, stridor, respiratory distress, and significant risk of suffocation due to obstruction by membrane and local soft tissue edema. And if it is the emergency, if it is not treated immediately, the patient may die. So after respiratory tract diphtheria, number two is the cutaneous diphtheria, that is the skin on the lesions. So superficial, how are the lesions? Superficial, thymic, non-healing ulcers with a grayish brown membrane, and extremities are more affected than trunk or head. Pain, tenderness, erythema, and exudates are typical features. Hyperesthesia is unusual. So this is the diagram. You can see this is the cutaneous diphtheria. Grayish brown membrane is there, and there is deep ulcer. Then third one is the infection at other side. What the corynebacterium diphtheria can affect which sides? like it can affect the ears and causes otitis externa. It can affect eyes and cause purulent and ulcerative conjunctivitis. It can affect genital tract, so purulent and ulcerative vulvovaginitis may occur. So these were the common types of the diphtheria and their clinical features. Now, what are the complications? Most dangerous is the respiratory tract diphtheria. As you know, if it can obstruct the respiratory tract and then it becomes emergency, I told you. So respiratory tract, if it occurs in a respiratory tract, then there can be respiratory failure. If it occurs, it affects heart, then toxic cardiomyopathy, that is also one of the emergency. So it causes tachycardia, arrhythmia, congestive cardiac failure, and sudden death. If it affects kidney, there is tubular necrosis. So in turn, the patient will get oliguria and proteinuria. It can affect nervous system, so it can cause toxic neuropathy, palatal paralysis, as in the second week, and causes nasal twang, that is the regurgitation. If it affects eye, ocular palsy in third week, that is the loss of accommodation, blurring, inability to read, and then generalized polyneuritis. Now, how to diagnose? First, whenever you see the take the history and examine, and if you find a typical pseudomembrane, so you should be having a high index of suspicion in your mind. And then rapid diagnosis by the Albert stain of the swab from the oropharynx or larynx. And third one is the culture from the site to isolate the organism. Now, what are the differential diagnosis? I already shown you the in the diagram. Fascial diphtheria, it is exudative pharyngitis by Streptococcus pyogenes, Epstein-Barr virus, and Vincent angina. We have to differentiate from this. Second is the all viral and bacterial causes of rhinitis and laryngotracheitis. Third is the in the cutaneous diphtheria, you have to differentiate from the streptococcal or staphylococcal impetigo. So treatment is very important. As soon as the diagnosis of the diphtheria is confirmed, you must first do quickly neutralization of bacterial toxin by intramuscular or intravenous administration of ADA, that is the anti-diphtheric antitoxin, and it is the mainstay of therapy. Its dose is 20,000 to 1,20,000 units based on the degree of the toxicity, size of the membrane, and duration of the illness. It should be given as soon as infection is suspected. Even you should not wait till the confirmation, because otherwise it may cause more harm. So it should be given as early as possible, even when suspected. And so neutralization is only because it neutralizes only free toxin, but it does not neutralize the fixed toxin. So once the toxin is fixed, it will damage the tissue. So then it will not be able to prevent further damage. So damage can be prevented by this neutralizing the circulating toxins by ADA as soon as possible. Then degree of protection is inversely proportional to the duration of clinical illness. It means longer is the disease, it will the degree of protection by ADA will be less, because if the duration is already prolonged, already that toxins have fixed to the tissue and have already caused damage, and ADA will not be able to neutralize it. Then repeat dose can be given if response is suboptimal. After ADA, second mainstay of therapy is the antibiotics, because we have to kill the bacteria also which are circulating. So number one is the penicillin, aqueous crystalline penicillin G, 1 lakh to 1.5 lakh units per kg per day, 6 hourly IV or intramuscular for 14 days. Then injection procaine penicillin, 25,000 to 50,000 units per kg per day, 12 hourly, intramuscularly for 14 days. Then erythromycin, second choice is the erythromycin, 40 to 50 milligram per kg per day, 6 hourly, orally or intravenous maximum. It should be given 2 grams a day for 14 days. Antibiotic therapy is used to terminate the production and limit the bacterial proliferation and production and spread of organisms to contract and prevent the development of carriers, but it is not a replacement of ADA therapy. So by date, number one is the mainstay of therapy is ADA. Second number is the antibiotic to prevent the carrier stages. Then after completion of the therapy, two cultures from the sites apart 24 hours should be taken, and if both are negative, stop antibiotic. But if any one of the culture is positive, erythromycin therapy is repeated. As clinical disease does not confer the active immunity, the therapy should be followed by the active immunization. So after that, active immunization should be done. Supportive care, isolation to prevent the spread. Second, bed rest for 2 to 3 weeks. As you know, it can affect the heart, it can affect nervous system, it can affect kidneys. So bed rest for 2 to 3 weeks. Monitoring for airway obstruction. If there is airway obstruction, immediately tracheostomy can be done. Cardiac monitoring and avoidance of sudden exertion. Then, if there is palatal palsy, nasogastric feeding should be done by the tube. And most important is the prevention and control. Isolation of patient until two cultures are negative, because till that time the patient is infective to others. So I told you, if any one of the culture is positive, we have to repeat the course of the antibiotic erythromycin. Second, disinfection of all the contaminants and articles, chemoprophylaxis with the erythromycin for 7 days, or single injection of benzathine penicillin to all the household or other contacts of the patient. So this is the 7 days of oral antibiotics or one injection of penicillin must be given to all the contacts. Booster doses of diphtheria toxides to previously immunized symptomatic patient or fully immunized also has to be given. So now second infection, most important infection is the pertussis, or it is also known as the whooping cough. So pertussis means intense cough. It is an acute, highly communicable disease of the respiratory tract, and it is caused by the commonest organism is the Bordetella pertussis, occasionally by Bordetella parapertussis in humans and Bordetella bronchoseptica in animals. How does it spread? Exact mechanism of disease is unknown, but Bordetella remains tiny gram-negative coccobacilli that colonizes ciliated epithelium of respiratory tract and damage it and initiates inflammation and interference of pulmonary secretion clearance. It is highly contagious infection, and its attack rate is in susceptible individual is exposed to aerosols droplets. Outbreaks of pertussis are reported worldwide since 16th century and was the leading cause of death in children even in developed countries before the introduction of the wholesale triple vaccine DPT in 1940, which led to 99% decrease in causes. So this was the revolutionary revolution in to control this disease in 1940. Before that, it was the main leading cause of the death. So this disease continues to be endemic in India, but of course the incidences are very much reduced. Podella pertussis does not survive in environment for prolonged time. So chronic carrier in humans are not known like of diphtheria, but after intense exposure, as in household contexts, the rate of subclinical is infection is very high, as 80% in fully immunized and naturally immunized individual also. So there should also be given the treatment. Protection against typical disease wanes 3 to 5 years after vaccination and is unmeasurable after 12 years of age, and that is why booster dose is required. What are the clinical features of whooping cough? Incubation period is 7 to 14 days. Severity of clinical feature depend on various factors, that is the age. It's more severe in infants less than 3 months. If the immunization status of the patient is low, then there will be severe infection. Passively acquired immunity, then there can be low grade infection. degree of exposure. If there is high amount of or a high dose of exposure is there, the patient may get severe symptoms in spite of the immunity. And genotype of organism, the course of the disease is prolonged and can be divided into three stages or phases. So our first stage is the catarrhal stage, second is the paroxysmal stage, and third is the convulsant stage. So I will tell you shortly. Catarrhal stage lasts for 1 to 2 weeks in most of the infections. And initially, it starts with a mild respiratory infection. The child has coryza, running nose, and with little nasopharyngeal secretions, sneezing, fever, and mild cough, which becomes more severe and frequent with passage of time. That is unlike cough of URI, which resolves by the as the time passes, but it becomes worse. Second is the paroxysmal stage. So after 1 to 2 weeks of the catarrhal stage, this starts and it lasts for 2 to 6 weeks. So it is very long in duration, in which cough progresses to episodic paroxysmus, bouts of increasing intensity cough, and ending with a high pitch inspiratory whoop. Like this, there will be high inspiratory whoop. The whoop is produced by the air rushing in during the inspiration through the half open glottis. So the whoop may not always be present as in infants. That is known as there may be apnea or cyanosis instead of the whoop. And it is also, so because of its duration, it is also known as the cough of 100 days. In infants less than 3 months, this stage may be considerably prolonged sometimes. And then comes the convulsant stage. And convulsant stage, this intense and paroxysmal cough decreases gradually over 1 to 4 weeks. And then the patient starts gaining the appetite also, general condition improves, and gradually improves the further in the last 2 weeks. And it is cough of, I told you, all like 100 days. So this becomes total, if you calculate all the three stages, it becomes cough of 100 days. Now, next slide is important for you, complications. This rate is very high in infants less than 6 months. Young infants show apnea, pulmonary hypertension, subcutaneous emphysema, umbilicus, and inguinal hernia because of the forceful cough. Rectal and rectal prolapse also as a complication of the severe and forceful bouts of cough. Then respiratory complications, otitis media, then one pneumonia, and atelectasis, emphysema, bronchiectasis, pneumothorax, and pneumomedistinum. Then neurological complications, seizures, encephalopathy, polyneuropathy, bleeding episodes, epistaxis, retinal or subconjunctival bleeding, intracranial hemorrhages. Malnutrition and failure to thrive is due to the persistent vomiting and difficulty in feeding. Then flaring of the tuberculosis. If there is a latent focus in the body, it will flare up due to this infection. Differential diagnosis already viral respiratory infection like adenovirus and respiratory syncytial viruses. Then atypical organism may be mycoplasma or chlamydia. Then chronic pulmonary conditions like hyperactive airways disease, cystic fibrosis, bronchiectasis, fungal infection, endotracheal tuberculosis. Then gastroesophageal reflux disease, GERD or GERD, considered in a small child with prolonged cough. And sometimes it can be confused with the inhaled foreign body also. But inhaled foreign body will be having an acute presentation and acute onset of the respiratory distress. Now, how to approach the diagnosis? Diagnosis is usually clinically. Certain hematologically investigations may help to support the diagnosis. First is the isolation of organism in appropriate medium, that is the gold standard. Second, documenting presence of organism by PCR or direct fluorescent antibody testing, that is DFHA. Third is the leukocytosis with absolute lymphocytosis with low ESR. They are the supporting evidences, diagnostic evidences. Now, how to treat these children? Principles of treatment: more severe cases and infants less than 3 months should be hospitalized and should be kept in the ICU with intravenous fluid, oxygen inhalation, frequent suctioning, and nutritional support. Then avoid paroxysm of coughing in mild sedations to allay the anxiety of the parents. Comfort during the paroxysmal, humidification of air to decrease the viscosity of the mucus. So the patient is relieved because of the thick secretions. Then clearing of the airways by gentle suctioning, mucus and vomiting during paroxysms to prevent the inhalation. There should be frequent suction. Then early recognition and treatment of complications and maintaining good hygiene and reasonable nutrition. Now, what are the choices of antibiotics in this? Uh, any of the macrolides in young and older children. Number one is the erythromycin in the dose of 40 to 50 milligram per kg per day in 4 divided doses for 14 days. And in the children, if the children is the more than 1 month of age, then azithromycin 10 milligram per kg per day in OD dose orally for 5 days for neonatal pertussis. Then clarithromycin 50 milligram per kg per day in 2 daily divided doses orally for 7 days. Then after macrolide, second choice is the cotrimoxazole in the dose of 8 milligram per kg per day of trimethoprim in 2 daily divided doses orally for more than 2 months of age. How to take the care of the contacts? I told you that it affects badly to the even immunized contacts also. So all household contacts, irrespective of their immunization status, should be given erythromycin in 40 to 50 milligram per kg per day in 4 daily divided doses for 14 days to limit the secondary transmission. Then prognosis is that infants have poor prognosis with high risk of neurological complications. Then the disease is more severe in unimmunized and partially immunized children, and they may also have complications. So prevention is the best part of to control any disease. Natural disease does not provide a lifelong immunity. Vaccines also provide a maximum protection of 10 to 20 years. So NIS, that is a National Immunization Schedule, recommends 3 primary doses of whole cell DPT vaccine at 6, 10, and 14 weeks of age, followed by 2 booster doses at 18 to 24 months, and second is at the 5 years of age, provide 70 to 80% protection against serious pertussis. Then pain and fever are due to pertussis component. So American Academy of Pediatrics recommends 3 primary doses of DTAP, that is acellular pertussis, but IAP recommends whole cell vaccine, that is DTWP, only for primary immunization. So there are 2 types of vaccines for primary immunization. Whole cell vaccine, which may give rise to pain and fever, and second is acellular component of pertussis in DPT, that will be painless and there will be no fever. So this can be given. हाँ दो तुम्हारा राउंड हो गया क्या? राउंड हो गया क्या? ये मेरे साथ हाँ. भरोसा का नीचे हो क्या?
हाँ नीचे गया।
बस आ गया साहब, बस नहीं हुआ है, सिर्फ परटूसिस हुआ है। हाँ